So good morning, good afternoon, or good evening, depending from where you are joining us. During the post-acute phase of COVID-19, patients were at increased risk of developing mental health disorders. And evidence have suggested that beyond the first 30 days of a positive test result of SARS-CoV-2 infection, people with COVID-19 showed an increased risk of anxiety disorders, depressive disorders, stress and adjustment disorder, opioid use disorder, and other non-opioid substance abuse disorder, neurocognitive decline, and sleep disorders. And despite that, across the MENA region, the COVID-19 pandemic is taking a significant toll on the mental health and psychosocial well-being of individuals from all fractions of the society. Mental health in times of coronavirus in the MENA region, unfortunately, remains unaddressed. Today, our first speaker, Professor Wael Shamsuddin, will discuss the impact of COVID-19 on the mental health of adults and adolescents. But before introducing for you Professor Shamsuddin, allow me to thank Janssen for sponsoring this educational activity. Professor Shamsuddin is an assistant professor at the American University of Beirut Medical Center and an adjunct assistant professor at University of Michigan, USA. And for the past few years, Dr. Shamsuddin has been practicing child, adolescent, and adult psychiatry. He is also the director of Child and Adolescent Psychiatry Training Program at AUB-MC and has received the Teacher of Year Award at AUB and University of Michigan. His research focuses on treatment of ADHD and mood disorders and impact of stress, trauma, and grief on mental health, particularly among adolescents. He has been granted several research awards and has more than 49 peer-reviewed articles. Professor Shamsuddin, we are honored to have you as a speaker with us tonight. Welcome, and the floor is yours.
Thank you, Dr. Zainuddin, and thank you for having me tonight. Hello, everyone. As Dr. Zainuddin, I mentioned good morning, good afternoon, or good evening, depending on your time. So let me just share my screen. Do you see my screen?
Yes,
okay.
Yes.
So my talk is going to be about the impact of COVID-19 on the mental health of adolescents and adults. So for my talk, I'm going to follow this outline. I'm going to start with a background, talking about the impact of, briefly about the data we have about the impact of prior pandemics, coronavirus pandemics like MERSA or SARS on the mental health being. Then I will move to the talk about the impact of the current pandemic on quality of life, on psychiatric illness. Then I will talk about parenting and child behavior. I will move later to talk about cognitive effects of the current pandemics and finalize that with a conclusion. So starting with the previous literature, early on with the pandemic, there was this meta-analysis in which its authors, they compiled previous published articles about previous pandemics related to coronavirus in this meta-analysis. So what they did is they screened the literature. They started with almost 2,600 articles, and they, based on certain inclusion and exclusion data, they included 72 articles in their narrative and 7 studies in their meta-analysis. Those studies were representative of different age groups, with some studies having average age groups of 12.2 years and then up to 68 years. So from a wide range of age, from children, adolescents to geriatric populations. Geographically, they were from the Far East, including China, Hong Kong, South Korea, to Middle East region represented by Saudi Arabia, and then including European countries and North American countries like Canada and USA. And the follow-up time included in those studies was also big and large, and it varied from 60 days to up to 12 years post-illness, so long-term follow-up. So in this meta-analysis, they divided the outcomes depending on the acute illness and post-illness. What they found was that in the acute illness, there were common psychiatric symptoms, with the most common one being insomnia, like almost in 42% of patients who presented with SARS or MERSA. So, and the variation were from 20% to 50%, half of those patients were struggling with insomnia. This was followed by anxiety, around 35%, impaired memory was also around 35%, 1/3 of those patients. And again, 1/3 had depressed mood. Around 1/4 of patients struggled with confusion, and this ranged from around 20% to 36%. So the range on all of those studies was comparable with respect to prevalence of those psychiatric symptoms. Unfortunately, the psychiatric symptoms was not limited to the viral infection itself, but it could have been also caused by the treatment, particularly by the steroids that could have been prescribed for some patients, though the prevalence was so low. So around 1,700 patients were prescribed steroids. Around 1% of them, like 13 patients, they had steroid-induced mania. So even the treatment can cause psychiatric symptoms, and we have to be aware of that and monitor the patient closely. With respect to the post-illness, the most common psychiatric problem was memory impairment in around 1/5 of the sample, followed by insomnia, anxiety, and irritability, which were comparable around 12 to 13% of the population. And around 10% they had depressed mood. And again, the range in those different studies was comparable. They looked at the different psychiatric disorder as a diagnosis. Earlier, they were looking them as symptomatology, but with looking whether they had this psychiatric disorder. There were 3 studies that looked at prevalence of anxiety disorder with a range ranging from 14% up to 17%, and the pooled percentage was 15%. So all studies were comparable. Similarly, for depression, there were 5 studies looked at prevalence of depression as a psychiatric diagnosis, not as a symptomatology. And the prevalence ranged from 11% up to also around 17%, with the pooled prevalence was around 15%. There were 4 studies that looked at PTSD, post-traumatic stress disorder, not like due to other trauma, right? Due to having the illness itself and recovering from the illness. And similar prevalence rate, 14 to 17%, with pooled average of, it was from 25% to around 45%, with a pool prevalence of around 30%. So it was PTSD more prevalent among those patients. So this was the early data that was available early in the pandemic. And later on, there were different studies looking at impact of COVID-19, whether the illness itself, infection, comparing individuals with the illness compared to individuals who did not get the illness, or looking at in the general population about the impact of lockdown and the change in lifestyle, and with what that carried, like the financial impact and things like that. So because of that time constraint, there's no way to present all the data. I tried to get 1 or 2 studies to represent different areas, and try to look not only at studies that looked at prevalence, rather than studies that had comparisons to be able to make more conclusions. So one study, they took 58 COVID-19 patients post-hospital discharge, and they matched them with the 30 controls, the oranges for controls. And those controls were matched with respect to age, sex, and body mass index. And the evaluation was around 2 to 3 months after the onset of the disease. So they gave enough time for recovery. So the ones in blue, they reported significantly lower quality of life compared to the control group. And that was in particular with respect to limitation on their physical role and their emotional role. Physical role to do a job, for example, or to study if they are a student or things like that. Emotional role to be able to provide, for example, emotional support to family members or for example. And so we see like the big difference with respect. So the number is how the percentage, if they are functioning 100% at their normal level, 80%, 60%, up to 0%. So with respect to the limitation on physical role, after recovery, 2 to 3 months after the illness, they were only at 22% of their physical role compared to 100% role for controls. And similarly for emotional, they were like around 30% for the recovered patients compared to 100% for controls. There was impact on other aspects, but to less degree, like energy, emotional well-being, pain, and general health or physical functioning. And there was also impact on social function, 100% for the control being around 50% for patients who recovered from COVID. When looking at psychiatric illness, they used the PHQ-9 and the GAD-7. These, as many or most of you might know, these are tools that commonly used to screen for depression and for generalized anxiety disorder. So those figures, they represent those with the recovered, not the controls. So with the recovered, they had like around 60%, they had minimal depression, and this was less than 75% in the control. Both groups were similar with respect to mild depression, 25% for the recovered patients compared to 20% of controls. But when we moved to moderate and severe depression, these were statistically more prevalent among recovered patients, with 5% compared to 3%, and here 9% compared to 0%. So more of moderate and severe depression among recovered patients. Similarly, for the respect to anxiety, this figure for recovered patients, this is 57 for recovered patients. It was more 70% for the controls. So controls would be more in the minimal symptoms of depression and anxiety, while recovered patients would be more in the moderate and severe. So this is 12% moderate anxiety for recovered patients compared to 3% for the controls, and this was 7% of recovered patients compared to 0% of controls. So, and again, this was looking at those who got COVID versus those who did not get COVID. But other studies looked at, in general, like what was the impact of the pandemic and the lockdown. And even individuals in general population who were not, who did not get COVID, they were reporting higher rates of anxiety and fears. And when asked about different themes that could have caused their worsening anxiety or fear, the themes there were related to fear of not being able to get out to get their treatment for chronic disease, like patients with chronic diabetes or hypertension or whatever. Among patients with mental illness, they were concerned about not being able to go to psychotherapy. Later on, the good thing about in psychiatry, telepsychiatry was a suitable alternative, which was able to bridge a big gap in the mental health services. And of course, worries about family members with a chronic disease. These were among the themes that, in addition to worrying about getting the COVID, commonly reported in the population as provoking anxiety, being anxiety provoking. In addition to anxiety and depression, there was a higher rate of PTSD due to getting the COVID infection. So this was a study performed in Rome, in Italy, in which they got around 400 patients who presented to the emergency department with COVID-19 infection. And after recovery, post-recovery, they referred them to a health check where they did a comprehensive medical and psychiatric assessment. And surprisingly, like the prevalence was around this 30% among COVID-19, prevalence of PTSD was around 30% among COVID-19 survivors. It was similar to survivors of 2006 Katrina hurricane, and more than the 25% prevalence reported in the earthquake in Japan in 2011, and even more than the 20% reported by residents near the World Trade Centers after September 11 attacks in 2001. The only group that had higher prevalence of PTSD was those who were survivors of 2002 MERS or the 2012 SARS survivors. And it could be because some of those groups were, some of those pandemics were associated with higher rates of mortality. But anyway, like we can see that COVID infection for those survivors was associated with higher PTSD rates than some of the natural or human-made disasters. So moving to other kind of psychiatric problems, sleep problems. And this was a meta-analysis rather than looking at individual study. This was a meta-analysis that looked at almost 1,300 studies. They had certain inclusion and exclusion criteria, and they limited that into 44 studies. In the 44 studies, they had ranging rates of prevalence of sleep problems, regardless of the tool used. And the rates ranged from around 8% into around 91% on the most common studies. The pooled estimated prevalence rate was around 35.7 in those 44 studies. When then they looked at the analysis, this meta-analysis, like into subpopulations, they found like in studies that looked at particularly patients who had COVID-19, they found that those studies reported higher rates of the prevalence of sleep problems compared to the general population. So the prevalence in the samples that had COVID-19 reached 75% as a pooled sleep problem, which would be double of this general population number. So which suggests that COVID-19 would be associated with sleep problems. When they looked at studies that examined particularly healthcare workers, the pooled number for those studies was 36%, which was similar to the general population. So care workers were as affected in this pandemic or had similar prevalence of sleep problem rates as general population, but COVID-19 had double the rates. Among patients with COVID-19, sleep problems seem to be associated with higher age. As we expect, geriatric population are more likely to have sleep problems or poor quality of sleep. And this was also associated with the gender, with male patients being more likely to have sleep problems compared to females having COVID-19. Moving to another topic, how did the pandemic impact parents, parenting, and children? So like the general population, looking at depression and worry, this was a study, nice study that was being performed in the US starting 2017-2019. In that period of time, they were recruiting families with the children to perform an intervention to families. So the average age of children was around 7 years prior to pandemic. And they were following them up, and then they were able to assess them in 2020, few months after the start of the widespread pandemic in the US and the widespread lockdown. So in a sense, they were able to assess, so this was longitudinal, they were able to assess rates pre and post COVID-19. And what they found that depression rates scores increased over time among parents. It was significant, and same thing with worries. And parents were 2.4 times more likely to report higher levels of depression during the pandemic compared to the pre-pandemic levels. And this was a few months into the pandemic. So imagine how were the rates like around 1 year later or so on and so on. There were factors that they looked how that those interacted with the depression and the pandemic, and they noticed that the increase in depression was among both mothers and fathers, with mothers being more impacted with the pandemic than fathers. So both had increased scores of depression, but the scores increased even further among mothers compared to fathers. The increase was regardless of education. There was increase among high school or less or more than high school. Regardless of the income, there was increase in high among those with high, middle or lower income. And there was increase whether the parents were had high conflict or low conflict. High conflict at baseline, they had high depression, and then they increased. Low conflict, they had low depression, but with the post-COVID, there was increase, a lot more increase in their depression, reaching comparable scores to those with the higher conflict, which seemed like a pandemic impact on the parents, as if they had a big conflict among themselves. This unfortunately reflected on both co-parenting quality and parenting quality. And co-parenting quality, it means that both parents, they have similar goals or they support each other. So this would be asked by instruments that have questions like my partner and I we have the same goals for our child, for example, or my partners makes me feel that I'm doing the best I can to help our child, things like that. Parenting quality, it's how each parent is providing care for the child. Like questions like would be like, I spoke to my oldest child in a warm and friendly manner, or I'll show my child that I like them the way they are, for example, how they are supporting their children. So this is parents among themselves, if they have similar goal, if they are supporting to each other, and this is their care of their child. Unfortunately, both significantly decreased over time, co-parenting quality and parenting quality. And this was among all groups of income, but mostly seen among middle income groups. And unfortunately, this reflected on symptoms among kids, internalizing symptoms, which would be depression and anxiety symptoms. Externalizing symptoms are behavioral symptoms. So over time, there was significant increase in internalizing symptoms among children, increase in the scores of depression and anxiety, and similarly significant increase in externalizing symptoms. And parents were 2.5 times more likely to report that their child was having or she was having externalizing symptoms compared to the pre-COVID, and 4 times more likely to report internalizing symptoms post-COVID compared to pre-COVID. So, and this study was in a sense reflecting multiple factors. Some of those factors could be the lockdown, and that was detrimental on the mental well-being of the children, but it also could have reflected the impact of the parental worsening depression, worsening anxiety, and worsening parenting styles. And we know from previous studies that the well-being of the child is related to the well-being of the parent, whether the mental health well-being or the physical health well-being. So for this example, in this study done in 1990, they followed children from age 0 to age 19, and they classified them into 4 groups. Group with the normal parents, they didn't have mental health or physical health problems. parents with medical illness, parents with bipolar, and parents with unipolar depression. And children over time of parents with depression reaching up to 70%, they were having internalizing or externalizing problems, compared to up to 40% with medical ill. Bipolar was a very small group, so it could have been not representative. And the lowest group was normal parents. In another study, they followed the children up into adulthoods of parents with no depression versus one parent having depression and versus two parents having depression. And both groups with either one parent or both parents having depression were more likely to develop depression compared to group of parents with no depression. So we know that the well-being of the parents has implication on the well-being of the child. So now with the pandemic, that was impacting directly the well-being of the parents, and directly impacting well-being on the child, and indirectly impacting the child through impacting their parents. So it was kind of double burden on the child. When we are talking in the MENA region, we should keep in mind certain populations like refugees, because in the MENA region, we have around 12.4 million people who are internally displaced within the MENA region. And the United Nations, through several reports, pointed that COVID-19 pandemic could exacerbate their older vulnerabilities and build up on those vulnerabilities. Unfortunately, there were no academic studies to look how that impacted this population in particular. But there were, for example, in Lebanon in 2020, multiple reports about increased incidence of suicide among refugees. So, but we don't have solid data to present. Moving to talk about cognitive deficits, and I will try to limit my presentation into 3 studies. One case control, one was a nationwide cross-sectional study, and a meta-analysis. So in this case control studies, they took 18 individuals with mild to moderate COVID-19, and they matched them with 10 health controls. And they evaluated them almost 1 to 3.5 months after recovery. They evaluated them using the modified telephone interview for cognitive status. So they were doing telephone interview with them. And they found like there were higher prevalence of attention problems, concentration problems, short-term memory problems, and trouble with finding words and fatigue. There was significant difference with the healthy control having better performance than COVID-19, post-COVID-19 patients. So COVID-19 impacted their cognitive status. And in looking into particular domains, there was no difference with respect to orientation. However, there was impact, COVID-19 significantly impacted attention, language and concentration, and memory. And this again was like 1 to 3 months after recovery. So that was considered to be a longer term outcome. In this study, there was no impact of age on the cognitive or the severity of illness. Severity of illness was measured by different days they spent in sickness, time to recovery, and whether they were hospitalized or not hospitalized. And none of those measures of severity of illness was associated with further worsening of the cognitive status. And it could be because of the smaller sample size. As I mentioned, it was 18 patients. So in certain occasions, there were some trends, but it was not significant. Even when they looked whether those patients were required oxygen versus no oxygen, there was no significant difference between those two groups with respect to cognitive impairment, whether they required medication or did not require medication. There was no significant difference. And when they were looked at different kinds of titers, whether IgG titer, ferritin, the PCR count for the SARS, interleukin-6, CRP, or D-timers, none of those was significantly associated with worsening scores, though there were some trends in that. Moving into another nationwide study, this looked at cognitive deficits, and this was a study was performed in Great Britain, looking at nationwide what was the intellectual level, and it was sponsored by BBC Two Horizon. So, and they were doing it online by administering those kind of tests online. This would be block rearrangement. It tests measure spatial problem solving. So we have those blocks, how we can rearrange some of them to get this shape. This what is Tower of London. They have to move those tiles to rearrange them from biggest to smallest, but there are certain rules applied. And this measure executive functioning. There is digit span, they have to memorize them. There's the spatial span, there's target detection, they have to detect this target. There's two-dimensional mental rotation, they have to figure which will be which one of the four options. They have to rotate it mentally to figure it out. They were tested with respect to analogical reasoning, with respect to rare word definition, and with respect to emotional identification, whether they can identify two pictures as they being same emotion or not being the same emotion. So in a sense, they were testing different cognitive areas that have different, that are related to different areas in the brain. So this test ended being administered to 81,000 individuals. When the COVID-19 pandemic started, they added questions related to COVID-19. So around 13,000 individuals indicated that they had suspected COVID-19. In this study, they found significant correlation between symptoms and impact on cognition. The group that had least impact on symptom was those with symptoms but not without respiratory symptoms. So they had symptoms of viral infections like myalgia but did not have respiratory symptoms. More impact on those with respiratory symptoms but not to the extent that they needed assistance. Then more impact on those who required assistance at home. And these groups were combined compared to this group. You can see the difference here. More impact on those who were hospitalized, but they did not require a ventilator. And most impact was on those who required hospitalization and required ventilation. So the more serious the illness, the more impact on their cognitive level. So the nice thing about this study, it allowed this kind of comparison in a big sample size. This association was easily detected, but it was a cross-sectional study. That was the limitation. So in this study, this was a meta-analysis, and they looked at different studies, and they found that there was impaired attention, 45% in studies that looked at short-term, and this was still present in long-term study, the study that I presented earlier. Similarly, with respect to impaired memory, it was 13 to around 28% short-term, it was 28 to 50% long-term. So there was long-term impact on cognition. With conclusion, we see that from previous studies about COVID infections and from the COVID-19 studies, there is an impact on the psychological well-being and on the cognitive level of the patients. This has, in addition to its direct impact, we know it can directly impact the physical well-being, because we know from previous study in normal course of events that people with established mental illness, they have lower life expectancy and poorer physical health outcome than the general population. So imagine that in those conditions where in addition to having COVID-19, there was lockdown and there were a lot of other constraints like financial constraints. And unfortunately, during those times, health and social care professionals are at particular risk of psychological symptoms, which would be impact their availability for to help support the general population. Thank you for listening. I'm happy to get questions if we have time for that.
Thank you, Dr. Wael, for an amazing lecture. And let us take some questions. So the first question, can you summarize for us the risk factors for developing mental disorder in patients who got COVID-19 infection?
So a very good question. It seems like usual in mental health, it's multifactorial. So definitely we cannot undermine the general factors that were related to social isolation, to financial stressors, to worrying about family members and so on. But unfortunately, with respect to COVID-19, multiple studies were showing that with the inflammatory markers, they were affecting the brain, forming a kind of encephalitis, and that was also having a direct impact on the mental health well-being. So if I want to summarize that in few words, I would say direct impact due to the virus itself, and indirect impacts because of the factors associated with the lockdown and with the lockdown.
Another question, if a family member is suffering from a pre-existing psychiatric illness and he just got a COVID-19 infection, is this a necessity to more frequent psychiatric evaluation and to seek emergent psychiatric consultation? And do those patients usually need any change in their current treatment?
So with respect to this patient, it depends on their performance. If they are doing well, fine. No, they can continue their routine checkup and routine treatment, whether it was with a therapist, psychiatrist, or both. Definitely, if there were furthering, if there was worsening of symptoms, then they need more intensive treatment on adjusting medications. With respect to medication, this is a good question. I failed to comment on that. We don't still have data to show that with those particular patients who are having those cognitive declines, whether the established treatments, the ones that we have, are effective, for those without history of COVID-19 infection, or no, they need different treatments. We still need to have studies looking at that to be able to answer those questions, but for the time being, we use the established treatments.
Another question, do we have any figures about the prevalence of depression post-COVID circumstances at any country in the GCC or even in the MENA region?
So in the MENA region, there were few studies in a few countries like Saudi Arabia, I remember, in Jordan, and I think one in Lebanon. The numbers were similar to what I presented, ranging between 20 to 40%. I cannot say for each country what was which number. The other thing, I cannot say for some countries whether that was an increased prevalence or similar prevalence, because I don't know the rates before COVID for each country.
I still have two questions. So the first one, what is the impact of a patient who got infected with COVID-19 and who already suffered from bipolar disease, and how we should help them to overcome this phase?
So definitely, as I mentioned, in general, there was a higher risk of worsening depression. So they are at risk of depression. When we say at risk, we are not saying it's risk. It doesn't mean 100% of patients are going to have worsening depression. So those studies help policymakers, help people they want to plan for healthcare services and so on. But they might not help us immediately on individualized level, because then we have to assess each patient alone individually to see if they have worsening of symptoms. Again, we become more aggressive in treatment. If they don't have, we continue with the regularly established treatment.
Still have many questions, but I don't want to delay Professor Yamut further, so I will take the last question. So the fear of getting contagion and persistent exposure to diverse medication and vaccination contribute enormously to develop mental health disorder and issues among people. So from a psychiatrist perspective, how can healthcare providers tackle this issue in the general public?
Good question. So I would like to say, just from personal experience, that usually people who tend to worry more about those issues are those who at baseline have more anxiety. And I said in general, I'm not saying some people might worry without having baseline of anxiety. But usually, like what I saw from my experience, that people who are worrying excessively whether they should take the vaccine or not and things like that are individuals with anxiety or generalized anxiety disorder. So definitely education, and especially if we're talking about general public and widespread intervention, education is very important. And for example, like vaccination, as we recall, like when the vaccine first came, we had a lot of things on social media about how this is monitoring us, how there's like copper and how copper can they follow us wherever we go and things like that. And definitely that would be anxiety provoking for the general public. So I think education, widespread education is important in addressing those issues and calming the anxiety of the public.
Thank you, Professor Wael, for being with us tonight and for answering all our questions. So we will move to the second lecture. Our second top-notch speaker is Professor Bassem Yammoud, joining us from Abu Dhabi. Professor Yammoud is currently Professor of Neurology at the American University of Beirut Medical Center. He received his training in neurology at the University of Cincinnati, Ohio, followed by a fellowship at the Montreal Neurologic Institute, McGill University. He is currently head of the clinical research at the Multiple Sclerosis Center of the American University of Beirut, president of MENA, fellow of the American Academy of Neurology, and member of the MSIF International Scientific Advisory Board and multiple regional and international MS Advisory Board. Dr. Yammoud is one of the leading experts on multiple sclerosis in the Middle East, with recent research on epidemiology, quality of life of patients in the Middle East, treatment, novel therapies such as stem cell and venous stenosis, and the impact of wars on MS. In addition, he is currently the principal investigator on several ongoing international MS trials. Dr. Yammoud has authored many research and review papers and is currently the chief editor of the MS newsletter MS Today and on the editorial board of the Multiple Sclerosis and Related Disorder and Pediatric Neurology. He recently moved to Abu Dhabi and he is currently the director of the Neurology Institute and MS Center at Harley Street Medical Center, Abu Dhabi. And since the spread of the COVID-19 pandemic has imposed significant challenges on healthcare provision of multiple sclerosis, requiring a change in the convenient MS management, particularly in patients treated with immunosuppressive disease-modifying therapy, Professor Yammoud will talk tonight about the management of MS during the era of COVID-19. The do and the don't. Professor Yammoud, you are always the most welcome. Please, you can start your presentation.
Thank you, Maya, for your kind introduction, and thank you for Osama for inviting me to join you today for this scientific activity. So I will be tackling the issue of MS during the COVID-19 pandemic, and I was also asked at the end to introduce to you the newest MS disease-modifying therapy on the market, which is ponesimod. So let's start with the first part of the presentation. These are my disclosures. So as you know, the coronavirus is an RNA virus. So you have an RNA core covered by a protein, and the most important protein in this cover is the spike protein. The spike protein is the protein that allows the virus to hook to the ACE2 receptor on the surface of the human cells and therefore infecting the cells. Once the virus is inside, the RNA is released, and through the ribosomal system of the cell, more proteins are synthesized and a new virus is assembled and then released. Once it's released into the system, it's caught by the antigen-presenting cells that will assimilate it and present the antigen to the immune system, mainly the T cells. The T cells, therefore, will activate both cytotoxic T cells and B cells that will produce antibodies on one hand, and on the other hand, they will destroy the infected cell with the virus. So this is your T cell immunity, and this is your humoral immunity. And through this memory B and T cells, you will be able to, whenever the virus is infecting the organism again, to fight it by reactivating the antibodies and the cytotoxic T cells. So this is just a nutshell about the pathophysiology of the corona or the COVID-19 virus. So let's go now about the effect of COVID-19 on MS. This, I think, is a very nice study that was presented by Maria Pia Sormani in a recent meeting. And this is taken from the Italian cohort registry. And it shows that actually MS patients are at a higher risk of severe COVID-19 infection. We can see here that the MS patients are in blue and the general population, let's say, in purple. So MS patients have a higher rate of death, higher rate of ICU admission, and higher rate of hospitalization. But this does not apply to all MS patients. There are specific risk factors that make an MS patient at higher risk of a severe COVID-19 infection. Most importantly is the age, especially age above 60 years. This is a very statistically significant risk factor for severe infection. EDSS, disability, advanced disability, the presence of comorbidity, for example, diabetes, cardiac disease, obesity, the use of IV methylprednisolone, which we frequently use for relapses, especially during the months preceding the infection. On the other hand, there are disease-modifying therapy that can increase the risk of the severity of COVID-19, and these are the B-cell depleting therapy, ocrelizumab, rituximab, and probably now ofatumumab. On the other hand, there are disease-modifying therapy that actually protect against the COVID-19, and mainly the interferon, which have shown in many studies to be statistically significantly protective against severe COVID-19 infection. And this is probably due to the fact that interferon actually have an antiviral effect. This is another study from the French cohort, the COVI-CEP, which again showed exactly the same results, that the risk factor for an MS patient to have a severe COVID-19 infection is age. The older, the higher the risk. Comorbidities like obesity and cardiac comorbidities, and of course, advanced disability. A much larger study, which was the Global Data Sharing Initiative, which studied more than 5,500 patients on different disease-modifying therapies, again identified the fact that B-cell depleting therapy that you can see here increase the risk of hospital admission and ICU admission, while all the other disease-modifying therapy for MS do not have an increased risk for any of these comorbidities. So the B-cell depleting therapy are really standing as the main disease-modifying therapy that can pose a risk for a severe COVID-19 infection, hospitalization, and death, actually. So based on all of this data, we published our MS International Federation guidelines. This is the last version a few months ago. The number one and most important recommendation is that people with MS should not stop their treatment while the COVID-19 pandemic is active, even if they are in the middle of a very high level of the pandemic. They should continue their treatment. Now, if the MS patient developed the infection, the actual infection, and tests positive, then he or she should consult their physician to decide about what to do with the treatment. Most of the time, we keep the treatment on. And finally, if we are in the middle of the pandemic, especially at the peak of the pandemic, like where a few months ago, for example, with the Omicron variant, then initiating new DMT should take into consideration the DMT that increase the risk of a severe COVID-19 infection, like, for example, the B-cell depleting therapy. So in general, the interferon glutamate acetate do not have any negative impact on COVID-19. And actually, as I mentioned, interferon might be protective. The oral treatment, dimethylphenidates, teriflunomide, fingolimod, cipolimod, again, all the available evidence suggests that there is no increased risk of severe COVID-19 infection. The anti-CD20 therapies I already mentioned are the only disease-modifying therapy that increase the risk of a severe COVID-19 infection. And finally, anatosumab and cladribine, we still don't have enough data, but probably the period where there might be a risk of a worse COVID-19 infection is the period when the patient are lymphopenic, which is a transient period with both medications. So let's move now to the issue of vaccine, the COVID-19 vaccines in general and with MS specifically. Now, of course, the vaccination rate is going up all over the world. And this is the statistics as of December 2021, so 3 months ago. More than half of the world population is already vaccinated. But the problem is that this vaccination is not really uniform. And some of the very poor countries, low-income countries, still have a very, very low rate of vaccination below 10%. And the problem with that is that these will be fertile grounds for the virus to multiply and therefore develop a new, more infectious and more resistant variants. And this is how, for example, in India, and we can see the very low rate of vaccination last year, this is where the Delta variant originated. And if you look now at the current rate of vaccination, we see, like, for example, the UAE, Portugal, Singapore, China have very high rate of vaccination, above 80%. While area in Africa, for example, like Tanzania, Nigeria, Ethiopia, Kenya, we still see rates that are below 10%. And look at South Africa here, around 30%. And remember, this is where the Omicron variant originated. So unless we have a uniform vaccination all over the world, we will not be able to protect against more infectious and more virulent variants in the future. Now, what type of vaccines do we have and how do they interact with MS? First, of course, we have the RNA vaccines, whereby the RNA codes for the spike protein. We have the viral vector vaccine, whereby the actual DNA coding for the spike protein is inserted into a virus, into the DNA of this virus. For example, the Janssen, the AstraZeneca, the Sputnik vaccines. The RNA vaccine, of course, like the Pfizer and the Moderna. We have the inactivated virus vaccine, which is not just like the flu vaccine, which, for example, the Sinopharm, the Chinese one. We're not using live attenuated viruses yet. And there is one current vaccine that actually uses the protein itself, the spike protein itself, to generate the antibodies. So how do these vaccines work? For example, if we take the RNA vaccine, the RNA for the spike protein is inserted and it's covered with a lipid coat so as to allow it to enter the cell. Once injected subcutaneously, this double layer lipid coat can enter into the cell. The RNA coding for the spike protein is released, and through the ribosomal system, the spike protein is produced, released into the system. Again, the antigen presenting cell will catch it, present it to the T cells, which will activate basically the immune system, both the B cells and the CD8 T cell. The B cell will produce all the antibodies needed that will hook to the virus and basically destroy the virus, while the T cell immunity will destroy all the infected cells. If we go to the viral vector vaccine, for example, the Janssen and Janssen, the AstraZeneca, the actual DNA coding the spike protein is inserted into the DNA of the virus. The virus, again, the vaccine is injected sub-Q. It goes inside the cell. The virus infects the cell, actually. The DNA is released into the nucleus. And this is where a new RNA is produced and released into the system. This RNA coding the spike protein, and that it follows the same pathway that I mentioned. So this is just a nutshell about how are our vaccine producing immunity. Now, if we look at the original phase 3 trial, we can see, for example, that the Moderna and the Pfizer RNA vaccine show a very high efficacy. We see 92% and 94%. The viral vector vaccine, like, for example, the Johnson & Johnson, the AstraZeneca, show a slightly lower efficacy. We can see 72% and 64%. The Sputnik, which is also a viral vector vaccine, but using 2 different viral vectors with each of the 2 vaccines that are 2 weeks apart, shows a little bit of a higher efficacy of around almost 91%. And finally, we have the inactivated virus vaccine, which are the Chinese ones, Sinovac and Sinopharm, and they show probably a lower efficacy, probably in the range, we think, about 50 to 60%. Now, are the vaccines safe? Like every vaccine, there are always side effects. Many of them are immune mediated, which is expected. But these are extremely rare complications, and we're talking about numbers in the million or in the hundreds of thousands. There has been cases of Bell's palsy that were reported with the Moderna and the Pfizer vaccine. There has been cases of transverse myelitis that were reported with the viral vector vaccine, Johnson & Johnson and AstraZeneca. And of course, we had the issue of the venous thrombosis, especially in young female, that was reported again with the viral vector vaccine. Of course, there has been many other reports, but we are not really sure that they're actually vaccine related and not just a chance occurrence. The Sinopharm actually and the Chinese vaccine had, as inactivated viruses, had actually low rate of major adverse events. Now, so this is for the vaccine, the COVID-19 vaccine in general, but how about the relation into MS and the relation and using them in patients with MS? Now, we just published our MENA practice guideline earlier last year, late last year, about how to manage COVID-19 vaccine with MS. And actually, Dr. Maya Zainuddin is one of the authors on this paper. The number one question and the first that we are always asked, can vaccines, by triggering the immune system, can they induce actually a relapse of MS? And there has been many studies that show that this is not the case. This is the Italian study that they look at 324 patients with MS getting vaccinated. And they calculated that the relapse rate before the vaccine and after the vaccine was very similar, around 2%. So there was no increased risk. This is another study by Achiron and her colleagues looking at 555 MS patients. And again, they showed that the vaccination rate following the vaccine is not really different from the relapse rate following the vaccine is not very different from the relapse rate over the rest of the year. So all the studies have really shown clearly that the actual vaccine is not really a trigger for a new MS relapse, which is really always a worry among our patients. And occurrence of relapse following a vaccine is probably just a chance occurrence. So based on that, this is the first part of our MENA guideline that patients with MS should be vaccinated against COVID-19. There is nothing to say that there should not be. The risk of COVID-19 disease outweigh any potential risk from the vaccine, the very rare myelitis case, the very rare Bell's palsy cases. And there is no theoretical reason or evidence from clinical trial to indicate that any of the currently available vaccine can pose any particular risk to patients with MS, meaning a risk of having a relapse. Finally, remember that there are certain risk factors that increase the risk of severe COVID-19 infection in certain MS patients. And this is a subpopulation that we really should make sure they get vaccinated. Patients with progressive MS, older age, higher level of disability, comorbidity, diabetes, blood pressure, obesity, cardiac disease. In this subpopulation, especially when we are during the peak of the pandemic, we should really be vehement about them getting vaccinated. How about the DMTs? Do the DMTs affect the COVID-19 vaccine efficacy? There has been many studies and all of them actually showed the same thing. This is the antibody response to the vaccine, and these are the different disease-modifying therapy in MS. And as we can see with all the disease-modifying therapy, we had a good vaccine efficacy with a good level of antibody produced, except for the anti-CD20, the B-cell depleting therapy. And remember, it's the B-cell that produce the antibodies. And all of our B-cell depleting therapy basically deplete B-cells completely for at least 6 months. And the second category is fingolimod, or the S1P receptor modulator, that are known as a mechanism of action to sequester all the lymphocytes, B and T cells into the lymph nodes, and do not allow them to go into the serum. So those two disease-modifying therapy do affect the efficacy of the vaccine and actually decreases efficacy significantly. Okay, sorry. So this is another study by the same group from Italy, Maria Sormani, which showed exactly the same thing. This is the level of antibody response to the vaccine, and we can see for all the disease-modifying therapy, the level is good, except for rituximab, the B-cell depleting therapy, ocrelizumab, and fingolimod, the S1P receptor modulator. So again, the same result. But Sormani and the group showed a very interesting thing. In blue is the Moderna vaccine, and in red is the Pfizer vaccine. And remember, both are RNA vaccine. And for all these disease-modifying therapies, the Moderna vaccine produced a better level of antibodies, as if it's more efficacious. And most importantly, with the B-cell depleting therapy and S1P receptor modulator, where we have a low antibody level, actually the Moderna vaccine did better. So one way to go around this problem in our patient on the B-cell depleting therapies and on fingolimod or other S1P receptor modulator is, if available, to use actually the Moderna vaccine rather than the Pfizer. Now, since the B-cell depleting therapy actually deplete B cells, and this is why we don't have antibody production adequately. What if we delay the infusion? We know that rituximab and ocrelizumab are taken by an IV infusion every 6 months. What if we delay the infusion 1 or 2 months and allow some B-cell recovery to occur? Will that help increase the vaccine efficacy? The answer is yes. And in this study by Moore and his colleague, they showed that if you give the vaccine below 7.2 months after the infusion, your antibody level is very low. But if you delay the vaccine beyond 7.2 months, then you start getting a good antibody level to the vaccine, so increase the efficacy. And the same apply if you measure your CD19 cells, which are the B cells. Again, if you're giving the vaccine early on, so you still have a complete B cell depletion, so a very low count of B cells, below 27 per microliter, you don't have a very good response of the antibodies. But if you have a number, and this was the cutoff they found, above 27 microliter cells per microliter, then we can see that we have improved significantly the response to the vaccine. So delaying the infusion of B-cell depleting therapy following the CD19 might be a way to get our patient on this treatment with efficacious protection from the vaccine. Now, if B-cell depleting if B-cell depleting therapies are depleting the B cells, how about the T-cell immunity? So in this study, they looked at the anti-CD20 medications, and we can see here in red the patient that did not build a good antibody level. Some of them do still build an antibody level depending on how delayed is the vaccination after the infusion. But let's look at those red dots, the patient that did not build antibody levels. When we looked at the T-cell immunity tested by the interferon gamma test, we can see that those same patients, you see the red dots here, have built actually a good T-cell immunity, and even better when they compare to the other disease-modifying therapies. So with B-cell depleting therapy, we know that although the B-cell, the humoral immunity is absent, the T-cell immunity is still present and actually even exaggerated. This is not the case with the S1P receptor modulators. Again, if you look here at the antibody response, and here the interferon gamma testing for the T-cell immunity, we can see that for fingolimod, for example, and the B-cell depleting therapy, there is a low level of antibodies. But once we test for the T-cell immunity, the B-cell depleting therapy have a good response. However, with fingolimod and probably the other S1P receptor modulator, the T-cell immunity is decreased. And remember that fingolimod sequester both T and B lymphocyte and the lymph node. And this is why both humoral and cell-mediated immunity is affected with the S1P receptor modulators. Now, the next question with the B-cell depleting therapy, if we have a cell immunity without the antibody, the humoral immunity, will this be protective against an infection actually clinically? This answer was provided partially by this recent publication just last month from the French registry. And actually, they looked at all their patients in Tecovicep, which is the French registry of sclerose en plaques, which is multiple sclerosis, all their patients that were actually vaccinated and got infected with COVID-19 in spite of the vaccine. And they found 18 such patients, 13 of whom actually were treated with anti-CD20 therapies and 4 with fingolimod. When they compared this number to the population of MS that were not vaccinated, among them, the anti-CD20 therapies represented only 20% of the patient, while in patients that were vaccinated and infected, B-cell depleting therapy accounted for 74% of the patients. So it seems that the lack of a humoral immunity and antibodies will probably still affect the vaccine efficacy, and maybe the T-cell immunity alone might not be enough to protect against the actual infection. But of course, we still need more data to answer that final question. So based on that, this is our table from the MENA guideline that we published recently, as I mentioned. When it comes to the effect of our disease-modifying therapy on vaccine efficacy, the interferon, glatiramet acetate, teriflunomide, dimethylfumarate, and natalizumab have no effect at all. So the vaccine efficacy is maintained, and you can give the vaccine at any point in time during treatment. For the S1P receptor modulator, of course, as I showed, the vaccine efficacy is affected, both the T-cell immunity and the B-cell immunity. So it's better to vaccinate 2 to 4 weeks before initiating treatment. But if the patient are already on treatment, do not stop treatment because you can run into the risk of having relapses. Just give the vaccine at any point in time and hope that they will build some immunity. Now, for alemtuzumab, we know that vaccine studies have been done with alemtuzumab and showed that after 6 months from the infusion, the vaccine can be given with good efficacy, or you give the vaccine before initiating treatment. With cladribine, same thing. Either you give it before starting treatment, or you can give it at any point in time after cladribine. Studies have shown that the lymphopenia in cladribine is transient and mild and does not affect really vaccine efficacy. Now, for the B-cell depleting therapy, ocrelizumab and rituximab, we did recommend to delay a little bit the infusion, maybe 7 to 9 months, following the CD19 count, allowing for some CD19 recovery, maybe 27 cells per microliter, or some studies have shown 10 cells per microliter, or actually 1% of the total count, and then give the vaccine. Of course, taking into consideration that the patient should be stable and well controlled on the treatment. Now, if you compare our MENA guidelines to the MSF, MS International Federation guideline, and the National MS Society of North America, they are very similar, exactly the same guideline, except for the B-cell depleting therapy, where both the MSIF and National MS Society still recommend to give the vaccine 3 months after the last dose of the B-cell depleting therapy, while we do recommend to wait until 6 months and delay it while following the CD19 to allow some recovery of the B-cell to improve the efficacy of the medication, especially that we know that these are the patients that really need a good protection, since the B-cell depleting therapy increase the risk of severe COVID-19 infection. So the final part of our MENA guidelines for vaccination MS, we stated that some DMT may make the vaccine less effective, but it might still provide some protection. And remember, most of the studies have tested the B-cell immunity, but more recent studies have looked at the T-cell mediated immunity and showed, for example, that it's preserved with B-cell depleting therapy, but not with S1P receptor modulators. So, but still, you do give the vaccine to all the patients, because there is always a % of patients that will do build immunity in spite of these disease-modifying therapies. And as I mentioned, especially for the B-cell depleting therapy, we have to coordinate the timing of the vaccine with the timing of the DMT, as I mentioned. And same for alemtuzumab, for example, where it's better to coordinate the timing 6 months after the infusion. Finally, the decision whether to give the COVID-19 vaccine anytime or to delay the DMT dose should include a risk-benefit evaluation. How much of comorbidity does this patient have? How much of risk for severe COVID-19 infection? Is this an old patient with advanced disability? Are we in the middle of the peak of the pandemic? All of these factors have to be taken into consideration when you decide to delay the B-cell depleting therapy infusion to allow for vaccine efficacy. So we move now to the second part of my presentation, where I was asked to introduce you to the newest disease-modifying therapy on the market in MS, which is ponesimod. Ponesimod is a new S1P receptor modulator. It was just approved in Europe a few months ago in June, and just arrived actually to the UAE 1 month ago. So it's a very new medication that you're going to hear a lot about it later. So I'm going to introduce some of the data and some of the information about it. So let's speak about the mode of action of ponesimod first. First, this is a selective S1P receptor modulator, and this is actually the label by Europe. It's indicated for the relapsing form of MS with active disease, so basically active MS. It's a selective S1P receptor modulator. It works only on the S1P1, while fingolimod, for example, work on S1P1, 2, 4, 5, and 3. Siponimod, for example, the one used for progressive MS, work on 1 and 5. Now, the S1P1 is the main one that is responsible for the effect on the lymphocyte, which is the lymphopenia I talked about, but it still has some effect on the cardiac cell, the erythrocytes. Ponesimod is given in a titration over 14 days. So you start with a very low dose of 2 milligrams and start increasing on a daily basis up to reaching the maintenance dose of 20. So it's a titration over 14 days at home until you reach the final dose, which is 20 milligrams per day, which is different kind of titration we've seen with the previous S1P receptor modulator. Before initiating treatment, the patient should get an EKG, just like we did with the fingolimod and the siponimod. There should be a CBC liver function test, ophthalmic evaluation for the possibility of macular edema, and looking at the VZV antibody. Basically, all of them similar to what we've seen with fingolimod, except there is no need for the blood pressure follow-up because there is no significant effect on the endothelial cell. And there is no need for monitoring. Remember, with fingolimod, you always monitor the patient for 6 hours for the first dose. With ponesimod, because of the slow titration over 20 days, there is no need to monitor because the slow titration will mitigate any of the cardiac side effects. You do monitor patient for cardiac abnormality with ponesimod if the patient have actually cardiac disease. So patients that are bradycardic below 55 beats per minute, or patients that have AV block, or patients that have history of MI, heart failure, and so on. So patients with cardiac disease or bradycardia should be monitored for at least 4 hours after the first dose. But of course, we rarely start S1P receptor modulator in these patients. This is as opposed, for example, to fingolimod, where all patients have to be monitored for 6 hours, irrespective of their disease. And of course, with siponimod, similar to ponesimod, we only monitor for 6 hours patients that actually have cardiac disease. Now, the efficacy of ponesimod has been shown in the Optimum study. The Optimum study is a phase 3 trial of ponesimod 20 milligram versus teriflunomide 14 milligram for 2 years. And the inclusion criteria, of course, were relapsing remitting MS that was with active disease. So at least 1 relapse in the previous year, 2 relapses in the previous 2 years, or GAD-enhancing lesion in 6 months. So any of these 3 will denote active disease, and these patients were included. And the results showed that ponesimod is superior to teriflunomide. It decreases the relapse rate by around 30% compared to teriflunomide. The number of patients that were relapse-free at the end of the study was much higher in ponesimod. 62% were relapse-free compared to 55% with teriflunomide. The effect on the MRI was also more pronounced, with 56% more reduction in gadolinium-enhancing or new T2 lesion with ponesimod compared to teriflunomide. The disability progression over 2 years was similar. So both teriflunomide and ponesimod had a similar effect on the disability at the end of 2 years. The safety of ponesimod actually was also very good. Compared to teriflunomide, for example, the serious adverse event was very similar 8.7 and 8.1%. Fatal adverse events were not, there were no fatalities with ponesimod, and there were 2 fatalities with teriflunomide. If we look at the specific side effect or specific adverse event for ponesimod, there was a slightly more hepatobiliary disorder with elevation of liver function tests with ponesimod compared to teriflunomide. We can see at 25% versus around 14%. The incidence of serious event was similar between the 2 medications. There was no increase in hypertension, as I mentioned because of the selectivity to the S1P receptor subtypes of ponesimod. There was a slightly increased pulmonary event, mainly infections. The heart rate rhythm, the development of actually AV block, which we used to see with fingolimod, was also very low. Only 2% developed any arrhythmia, mostly actually AV block. Herpetic infection was similar between the 2 infection and so on. And of course, there was cases of macular edema, just like we've seen with fingolimod, with around 1% of patients developing macular edema. This is why we still need to do the ophthalmology follow-up, screening and follow-up with ponesimod, just like we did with fingolimod. So the conclusion of the safety of ponesimod from the Optimum trial, number one, the up titration regimen over 2 weeks has really mitigated the cardiac side effect, as I showed in the numbers. And because of that, there was no need for the initial monitoring of the patient, cardiac monitoring during the first dose. We only monitor patients if they have cardiac disease, which I mentioned here. And finally, as I showed, over 2 years in the Optimum study, there was no significant increase in major cardiovascular event, and this was comparable to the teriflunomide because of the selectivity to the S1P receptor subtypes. Now, if we compare the safety among the different S1P receptor modulator, for example, ponesimod to fingolimod or ciponimod, the herpes infection actually was a little bit higher with fingolimod compared to ciponimod and to ponesimod. The herpes zoster numbers were very similar among all 3. Serious opportunistic infection, of course, we all know about the around 25 or maybe now 30 cases of PML with fingolimod, none with ciponimod or ponesimod, but of course, these are very new medications, so I don't think they had time to produce PML, but I would expect to see PML in the future. The macular edema incidence was also similar. All 3 of them had this very low incidence of macular edema. The elevation in liver function test was slightly higher with ponesimod compared to fingolimod and compared to ciponimod. As you can see here, around 17% had the 3 times upper limit of normal elevation compared to 8% with fingolimod and around 6% with ciponimod, so slightly higher. So the conclusion of the Optimum study, the phase 3 trial based on which ponesimod was actually approved in Europe. First, it's the first trial to show the superior efficacy of an oral DMT versus another, which is teriflunomide. And as I mentioned, it showed a statistically significant superiority of ponesimod versus teriflunomide when it came to relapse rate, proportion of patients free of relapses, and the MRI lesion. And when it came to ADSS, there was a similar effect of both medication over 2 years. And finally, the safety results are in line with previous observation from the other S1P receptor modulator. We did not see any really new signal about safety. Finally, an overview comparison between the different S1P receptor modulator. The license indication, we know that now ponesimod is licensed for active MS. Ciponimod is licensed in Europe. The label is for adult with SPMS, also active. Now, fingolimod is licensed for the highly active RRMS, and now recently has been licensed for the use in children, more than 10 years. The S1P receptor selectivity, as I mentioned, ponesimod is selective to the S1P1 only, while fingolimod acts on most of the subtypes, and ciponimod only on the subtypes 1 and 5. With fingolimod, there is no up-titration regimen. Both ciponimod and ponesimod do titrate over 14 days for ponesimod and over 5 days for ciponimod, and both these titration basically preclude the need for the initial monitoring. And this is really one of the most important differences is really the half-life. The half-life of fingolimod is 6 to 9 days. So if you count 5 half-lives to clear the medication, it's going to take you 6 weeks to clear it. While with siponimod, the half-life is 30 hours, it's cleared within 10 days. With ponesimod, it's 33 hours, it's cleared within 7 days. And which means that the lymphocyte count will recover once we stop fingolimod between 1 and 2 months, like we know. But with siponimod, it will recover within 10 days, and with ponesimod only within 1 week. And this becomes very important when you want to stop the medication, for example, to get pregnant, or to get a vaccine, or because of a serious infection, or because you're switching treatment. So in this case, you don't have to wait such a long time to reverse the lymphopenia effect. Finally, of course, you all know that siponimod needs a special genotyping for the CYP2C9 before deciding on which dose to use. I already mentioned the cardiac monitoring, which is used in fingolimod, and there is no need for it with siponimod or ponesimod, except for patients that have cardiac disease. Thank you very much, and I'm open to any questions. Back to you, Maya.
Thank you, Professor Yamout, for a very enriching presentation, and especially for highlighting the safety and efficacy of ponesimod. So as an organizer in the IVPN neuropsychiatry, we wanted you to elaborate more on the safety and efficacy of ponesimod, especially that 2 weeks ago we had an event, a multiple sclerosis event, and after that we received many questions from our members asking about this new drug. Please now allow me to take some questions. So the first question, as COVID-19 infection rate is decreasing worldwide, would you still have a concern on initiating patient on B-cell depleting therapy?
Definitely. The concern is much less now, which is also reflected in the fact that all the restrictions worldwide are decreasing significantly. Not only is the rate of infection lower, the new variants are much less virulent than the previous one, like the Delta, with much lower mortality and morbidity. The overall immunity in the general population, whether from the vaccines, as I mentioned, which is above 80% in many countries, but at least around 55% worldwide, and the natural immunity that we received from the widespread infection of the Omicron recently, which was very highly contagious, but produced mild disease. So it actually boosted all the immunity around the world. So for all of these factors, right now we have less and less concern about using B-cell depleting therapy. However, nobody knows in the future if we're going to start facing at one point in time a more virulent strain or a more contagious strain. But for the moment being, yes, I feel less concerned about the COVID-19. I think we're at the end of the line for that.
Okay, thank you, doctor. Another question, where do you place ponesimod in the current Menactrem's relapsing remitting guidelines, treatment guidelines?
Well, we haven't placed it yet because our guidelines were published last year, but probably whenever we're going to get to the newer guidelines, I think it will be similar to the other S1P receptor modulator that we have already in our guideline, which are fingolimod and siponimod. So it can be used as a first-line treatment in highly active disease, and it can be used as an escalation therapy from the first-line treatment when we're dealing with injectable dimethyl fumarate or teriflunomide.
So Dr. Sulaiman Al-Hawass is thanking you for an excellent presentation as usual, and he's asking you, what do you think of using teriflunomide as a comparator in the Optimum study?
We've been seeing more and more teriflunomide as a comparator recently, rather than the interferons, which we've seen before, for example, with the alemtuzumab trial, the ocrelizumab trial. And the reason is blinding. Because if you're going to use the injectables as a comparator, it's very hard to blind the patient because the injectable produce significant side effects like the interferon. However, with teriflunomide, taking a pill, whether it's ponesimod or teriflunomide, first they are similar, and you don't have to do sham injections for the double blinding. And the side effects from both medication acutely when taken is very minimal. So the main effector is the blinding. The other issue is that teriflunomide is an FDA and the MENA approved treatment for MS. So if we are able to show superiority to improve the treatment, then this is really very significant. Now, why don't we use higher efficacy medication as a comparator? I think the problem is with higher efficacy medication, it's going to take a much larger group of patients to show the difference between the two levels of efficacy. And this will not be financially feasible to have such a huge or such a large clinical trial.
Another question, can you highlight the advantage of ponesimod over the other available S1P receptor, S1P antagonist, receptor antagonist?
Compare it to fingolimod, number one, it doesn't need the initial monitoring. By doing this titration over 14 days, we are mitigating the need for the initial monitoring and therefore the initial cardiac side effect. The other, I think, main advantage will be the fact that it's much quickly reversible. So it takes between 4 to 8 weeks to reverse the effect of fingolimod when we stop it to switch or to get pregnant or to vaccinate, let's say. While with ponesimod, we are reversing the whole effect with full recovery of the lymphocyte within 7 days. So this would be probably another major advantage of ponesimod. But you have to remember that there is a rebound effect with the S1P receptor modulator, all of them. So although we are reversing the lymphocyte count within 7 days, you still have to watch for the rebound effect, just like we watch for it with fingolimod after the 2 to 3 months. So be careful about that point too.
And another question, do we need to do genetic testing for all patients to be initiated on ponesimod, or is it indicated for selected patients?
No, I don't think we need to do it for all of them, as opposed to siponimod, where genotyping is really needed to decide on the dose.
And a final question, what about lymphopenia with ponesimod? Do we manage it the same way we used to manage patients experiencing lymphopenia on fingolimod?
Definitely, but as I mentioned, the lymphopenia with ponesimod is very rapidly reversible. So this is going to make a difference in the way we're going to approach it.
With this, we still have one question. Any perspective about ponesimod and COVID vaccine?
I would expect it to behave just like the S1P receptor modulator by sequestering all the lymphocyte, the B and the T cells into the lymph node. It will probably have a negative effect on the efficacy of the vaccine, both cell-mediated and humoral. We haven't seen studies yet because it was just recently approved, but my expectation is that it's going to behave like the other S1P receptor modulators.
These were all the questions. Thank you, Dr. Yamut, for accepting our invitation despite your very busy schedule. And we will move to our last session. So our last lecture will be presented by Dr. Hajar Al-Mudayhim, who will discuss the clinical and economic burden of major depressive disorder in the MENA region. Dr. Hajar is a clinical pharmacist who graduated from King Saud University in 2005, worked in KSMC hospital, then joined the Regional Drug Information in KSA. She got her master's degree in clinical pharmacy in 2014. She was appointed as the head of National Drug Information Center at the Ministry of Health in 2015, established more than 50 centers across the kingdom. She operated 937 hotline from MOH 24/7 in 2014 with regional DIC around the kingdom to reach 60 DI specialist pharmacists and clinical pharmacists up to the state. Dr. Hajar was appointed as an advisor to the Assistant Deputy for Therapeutic Support Services and recently as a Drug Policy and Control Director. Dr. Al-Mudayhim have published several research papers and posters on drug information activities in Saudi Arabia. She's also a board member of the pharmacy profession under CSFH and FHS and a board member of the Saudi Society of Clinical Pharmacy under SCFHS. Welcome, Dr. Hajar. The floor is yours.
Thank you, Dr. Amaya. Thank you for having me today here. If you allow me, I will share my screen.
Yeah, sure. Go ahead.
Okay, great. So I will be talking about the clinical and economic burden of treatment-resistant depression in the GCC. In 3 countries, Saudi Arabia, Kuwait, and United Arab Emirates. So this is my conflict of interest. I have no financial relationship, and I will not be discussing any off-label use of medications. So before talking about our study, let's have a bit of a background on a major depressive disorder. So major depressive disorder is the second common illness leading to disability worldwide, and the prevalence of MDD is challenging to predict. However, it's believed to be 4.7 on a national level, and it's been revealed that in the GCC the prevalence was of 5%. In the GCC, 70% of all deaths are related to chronic disease. A neuropsychiatry disorder contributes between 40% to 20% of the overall burden of chronic diseases. MDD is one of the disease under the neuropsychiatric disorder, which is believed to be 42% till 45% of the total burden of the disease. According to the National Institution of Mental Health, for an individual to be diagnosed of a major disease or depressive disorder should have 5 possible depression symptoms, and at least one of those should be depressed mood or loss of interest or pleasure in activities, and these symptoms should experience almost every day for a continuous 2 weeks in more intensity than normal. So as we all know, the treatment of MDD encompasses psychotherapeutic, physiological, and pharmacological interventions. However, there is the availability of pharmacological and non-pharmacological agent. Approximately 30% of MDD patients do not respond to first-line antidepressant therapy, while 10 to 20% of MDD patients become resistant to multiple forms of therapy. This condition, where patients suffering from unipolar disorder does not adequately respond to a recommended dose of at least 2 different classes of antidepressants. This is the term of treatment-resistant depression, TRD. TRD patients unresponsive to treatment not only consume more healthcare resources, but as well adding more indirect costs, and it has believed that a patient with TRD is associated with 30% higher cost in medical expenditure compared to MDD. Despite the significant prevalence of TRD in the GCC and serious impacts in its on the productions of individuals, there is a substantial limitation of the evidence on the clinical economic burden of TRD in the region. So this is an objective of our study, is to try to quantify the burden of disease imposes on the Kingdom of Saudi Arabia, Kuwait, United Arab Emirates by TRD. And this was a model impact the perspective of a payer perspective. So as a methodology, we built the model based on burden of disease, and was developed to estimate the overall burden of the disease imposed by TRD across Saudi Arabia, Kuwait, and UAE. And the model was locally developed and perspective of a payer perspective. A literature review was conducted to develop the model concept and retrieve data input. Additionally, we had definite numbers of regional and local KOLs in order to get some insights and data gaps to be filled by their opinions or by their expertise. So as a first phase, the literature review was extensive literature review from clinical burden and economic burden as well. And we had eminent psychiatrists from Saudi Arabia and UAE, Egypt, Lebanon, and Turkey were consulted in patient's pathway and clinical pathway and management practices per country to validate the model concept. And based on the subsequent treatment alternatives to relieve depression, study START was one of the largest and most robust study ever undertaken by the National Institute of Mental Health. So we had the country patient population. So we had the country adult population, and then get the reflection of the MDD population and refract them by mental states of different phases. So we have a combination and augmentation, or augmentation alone, or integration with different, let's say, mental states or health states, from partial responder till the suicidal ideation that might patient would have a suicide related death. Our second phase was the KOL validation and the data collection. So we had 24 KOLs, as I mentioned, and we had face-to-face interviews to validate some secondary data and to have some information that we know that we have gaps in order to validate the model concepts. The second phase was the population of the model and generating the reports per each country. So this is the model inputs in regards to population inputs, and I will only be talking on Saudi Arabia. So Saudi Arabia, the total population of national and expats was about 33,400,000, and the population of population above age of 18 years old was 71%, which is equal to 23,700,000, and prevalence of MDD was, as we said, 5%. So we reached to 1,200,000 patients, and then the percentage of MDD patients and diagnosed was 55 or 56%, reaching to 676,000. And then the percentage of the MDD population without psychotic features was appointed by 90%. And then the percentage of MDD patients progressed to treatment of resistant depression was 21%, reaching to 100,000 patients. And then these are the transitional probabilities when we said the patient might be from partial response to non-response or remission after relapses or remission to recovery, reflecting the different layers, whether a combination, augmentation, or integration in different health stages. The drug costs, as you can see, different treatment options were reflected. So a number of SSRI or SNRI with the Saudi FDA registration prices, and the augmentation, whether it was antipsychotic or antimanic, thyroid, or anticonvulsants as well, was appointed by 50% from the treatment options. And then the electroconvulsing therapy as well was added into the options. Cognitive processing therapy as well was done, and the outpatient costs was reflected as well. Continuing on different treatment options, drug monitoring cost was added, and different adverse cost events were reflected as well. We had added the indirect medical costs from abscessism and presentism, and the with different modalities. So we had a total, the average treatment cost in Saudi was 4,400, and it is plus or minus the same for Kuwait, but UAE was 50% lower than Saudi. So the result in KSA, the overall cost by service provided. So if the patient has a first line and second line added antidepressants, and then different combination or augmentation and ECT, so you would see the total cost by service provider from treatment cost was reached to 1,400,000,000, and this is accounting by 9.7%. And the hospitalization and the productivity loss was the two highest cost representative, and it is about 70% of the total TRD economic burden. And you can see here the cost per patient, that again, productivity loss and hospitalization consume about more than 70% of total TRD patient management. And as we said that, if you can see here, the non-responder accounted to about 50% from the whole cost breakdown per health state. And this is similar to both countries, whether the UAE or Kuwait. So for the results in Saudi, the first analysis or first scenario analysis includes only adults of 18 years of age and Saudi nationals with TRD burden. The model estimated that at the end of 1 year time horizon, Saudi will be having 56 or 57,000 TRD patients with an overall economic burden of 8,171,000,000. The major driving factor of the burden of the disease was the productivity loss and the hospitalization, which accounted, as we mentioned earlier, about 70%. The second scenario added both Saudi and expat. You can see that it is it will inflate much more than the number of TRD, and this reflects the MDD patients as well. This is the Kuwait result, but again, you can see that major or the majority of the cost is the drug cost, representing of 60%. This is definitely might be related to not having more generics or the unavailability of certain medications in Kuwait. This is why we have driven costs by the drug, and the loss of productivity as Saudi. And again, the patients who are non-responder consume more than 50% in the health states. In UAE, the productivity loss was the main cost driver for TRD. It is opposite to Saudi and Kuwait. And the TRD management in the UAE rely more on the outpatient follow-up, including drugs and offices visits and monitoring, hospitalization. And now you can see how the patient's clinical pathways might differ from country to country. So the overall direct burden of TRD was estimated to be 15 billion Saudi riyal and 304 million Kuwaiti dinars, and about 200 billion 461 million UAE dirhams over 1 year period. for KSA and Kuwait and UAE respectively. This equates from 5% to 20% of the yearly health care expenditure in each country. So we are talking about 125 billion in Saudi and 1.5 million in Kuwait and about 45 billion in United Arab Emirates. The productivity loss was the greatest component of TRD, as we said, that it is more than 50% or 60% in range from Saudi, but in the for the three countries were ranges from 32 to 43% in the total. Across countries, the mainly costly line of therapy is ECT from the three different countries. And similarly, most costly health state are the non-responders, as we say that it is more or less the similar by the three countries, having it about 50% of the healthcare costs. And this is this study was comparable to different studies, and recent publication academic literature display a similar trend. So one of these studies has linked that there is an increase about 30% or 29.3% and 40% and 81% in direct cost in patients with TRD and MDD. So depression provides a challenge to any healthcare system simply because of the unusual combination of its characteristic. We know that it's a chronic disease. We know that it has no associated with any sign, signal, definitive diagnosis test, and there is a social stigma with those patients. And again, we do not have really data that reflects the real world evidence or in our countries when it comes to depression. Limitation of the study, as we know that we were conducting a lot with KOLs, and this was again the limited data, and there are uncertainties in different areas. So this is one of the limitations. And one more limitation is the model was not really reflecting the negative impact of quality of life in our study. And by this, I end my presentation. Thank you very much.
Thank you, Dr. Hajar, for an excellent presentation highlighting the economic burden and the clinical also burden of depression in our region. I would be happy to take questions if there is any. So Dr. Hajar, I have a question for you. So what about the rate? Did you study in the GCC, or did you have an idea about the rate of depression among patients who have chronic diseases?
Okay, this was an excellent question. I don't think that it was reflected in the in our study. It was not reflected. No, unfortunately, it was not reflected. But I mean, the GCC, and this is an approximately, was reflecting that patients who has with chronic diseases had in more MDD by 14%. And this is only an estimation that was not reflected in any KOL opinions.
And as an expert in the psychiatry field, so do you think that the cultural difference among our society would have impact the clinical burden of depression?
Definitely. Definitely. Patient would not will be hesitating, or the family will be hesitating or still be in denial that their family members or themselves might have this disease. And again, as I said, it is unfortunately a stigma, and people might shy, and this would reflect highly in higher expenditure of those patients, because they would be changing from different health state to a tougher state, or would be more into resistant depression.
And so, in your opinion, is depression still a taboo in our MENA region societies? And a lot of patients, they did not disclose their depression and their this feel of sadness to their healthcare provider. And from a pharmacist point of view, how should we encourage patients to talk about their depression to their healthcare providers?
Yeah, I think it is, unfortunately. And I think opening up more virtual clinics when it comes to depression, having these discrete, let's say, visits or clinics or communication, it would be much easier. And I think people will come and speak up more freely, rather than having an appointment and go to these hospitals. And it would be, I mean, the reach of these services would be, they might just give up and not go, but having this access would really facilitate or bringing or making patients speak up or reach out to a specialist. And in the Ministry of Health, we are already operating different virtual clinics, and one of them is the psychiatry clinic, and as well hotline by the Ministry of Health under the 937 hotline. Having any, let's say, if they wanted to speak up with a specialist or try to manage a call with a specialist, we try to schedule this as well for them, especially after the COVID. This was really something to work with.
And a final question, your study showed that 50% response rate on current standards of care. So what is the best protocol for those patients, in your opinion?
I mean, we need to make sure that I believe adherence is an issue.
Yeah, true.
Knowing that we do have, I mean, different pharmacological, and as we said, it's not only pharmacological. It is different. I mean, more than one component of the management. So having patients, or making sure that patients are adhered to their medication. One thing that we are developing now at the Ministry of Health is having a registry for patients with MDD, in order to monitor them, to make sure that they are adhered. We have a complete setup, a patient support program to follow up with these patients, or if they need any assistance in refilling, checking that they already have their refill, they already have their appointments booked, and having consultations in open dialogues. These are all, I would say, a complete system in order just to make sure that we are not just offering the top line or medications, but we need to make sure that the patients are adherent to their medications.
Yeah, I totally agree with you. So adherence is always affect significantly the efficacy of the treatment, not only for depression, but also for all mental health disease. And it's a major issue in patients suffering with mental health, because they always think that they can manage their depression or their mental health disease by non-pharmacological treatment. Thank you, Dr. Hajar, for sharing with us this very, very interesting study and data. And thank you for being with us tonight. At the end of this webinar, I would like to thank you and audiences. Thank our esteemed speaker for being with us tonight, Jensen for sponsoring this well-needed activity in our MENA region. And I want to remind you that you will receive your certificate of attendance by email within 1 week from today. If you missed any part of this webinar or would like to revisit the lecture, you can check our IVPN NeuroPsychiatry library, where we post all the records. Follow us on our social media platform and stay tuned for more neuropsychiatry activity in May, as we will take a short break during the holy months of Ramadan. Ramadan Mubarak to all of you, and until we meet again, stay safe. Have a good night.